So I'd like to make this talk a little more interactive. I'll need some assistance from anyone who is, you can read to me anyone who's typing in the chat box, okay?
Or I would add that as participants, if you'd like to raise your hand, we can also enable you to speak if that's easier.
So the topic is geriatric emergencies, and this is the essentials. It's a brief overview. I have no significant financial disclosures or conflicts of interest. By the end of this talk, we should be able to define an emergency, specifically a geriatric emergency, and discuss, you know, the relevance of having a discussion on this topic. Also, by the end of this presentation, we should be able to identify specific geriatric emergencies, to list some examples of those emergencies, and the respective diagnostic and treatment modalities relating to those specific emergencies. So why do we do what we do? And this is a question I ask frequently. Why do we do what we do? Why do we get up, get out of bed, come to the hospital? You know, why are we here on this Zoom presentation, you know, participating? Why do we do what we do? And that's an important question, okay? It's good to ask that question to evaluate ourselves, to assess progress and so on, assess goals. Before we get into that specific question though, I think it's important for us to ask, what is health? What is the definition of health? And there are different definitions. Anyone care to share? What is health?
Usually it means absence of disease or illness, but that's not the holistic definition.
Absence of disease or illness. So disease, like dis-ease. This means absence of an ease. So the absence of ease, disease. Okay. Is there a holistic definition? The WHO, the World Health Organization, defines health as a state of complete physical, mental, and social well-being, and not simply the absence of disease or infirmity. All right? There are many factors that impacts health. Previously, we mentioned in the prior talk, we commented on social determinants of health. There are many factors that impact health. The environment plays a role, medications plays a role, our spiritual lives play a role in our health, physical, economic, social, genetics, all these factors play a role in our health. So we kind of believe in the multifactorial or the web of causation of disease process, or the opposite of that, of health. Okay, so why do we do what we do? Simply put, we do what we do in medicine, and specifically in geriatric medicine, because what we do affects patient outcomes. Okay, what we do, meaning our assessments, what we do in terms of our interventions, it impacts the patient's quality of life, and it impacts life expectancy. And I think we mentioned previously that when we're dealing with a comprehensive geriatric assessment, we also want to promote independent functioning, right? So we want to ensure that that patient is able to perform ADLs and IADLs, okay? And everything that I'm saying here should be under the guidance of the age-friendly framework, okay? The 4Ms model, okay? Dealing with what matters to the patient, dealing with mentation, dealing with medications, dealing with mobility, okay? In the context of an emergency though, because we're dealing with time constraints, there's an emphasis is placed on stabilizing first, preserving life first, and then we'll deal with some of the other stuff, okay? So stabilizing, preserving, and hopefully that in and of itself will decrease mortality. Sometimes it's very difficult to decipher in an emergency setting what matters to the patient. Okay, and I'll leave that right there. We'll come to that in a minute. So what is an emergency? Any comments? What is an emergency? Or what would constitute an emergency as opposed to a routine visit? Any feedback? What is an emergency? What is a geriatric emergency? Okay, so an emergency is something that warrants immediate attention. It is a sudden and urgent, usually it's unexpected, but it's a sudden, urgent occurrence, usually unexpected, that requires quick, immediate action. The point is that if that action is not taken, it would translate into increased sickness, increased disease, increased disability, and or increased risk of dying. Okay, so it's an acutely debilitating or life-threatening condition in the elderly. Why is identifying an emergency important? This is where we would brainstorm. Yes. Dr. Gerard? Yes, Dr. Gerard, I see your hands.
I'm trying to unmute myself. There we go. I can't unmute myself.
We can hear you.
Oh, you can? Okay.
Yes.
My question was urgent to whom? Urgent because the insurance company will pay for it? Urgent because the healthcare provider thinks it's urgent? Or urgent because the patient thinks it's important? Those are dilemmas I think a lot of us face. You know, what is urgent to me and what may be urgent to another person may actually be different. And like for me, it comes down to, well, if the insurance company will pay for it, then it must be urgent.
Those are all relevant questions. And so I see where you're coming from. But my definition of an emergency is in the context of something where a situation where life, the situation where it's life-threatening and death may be imminent if an intervention is not taken, if something is not done.
So it's only physical health.
Your points are well taken.
Suicide, I guess.
Okay. So why isn't identifying an emergency important? I sort of answered it. Because if a decision is not made in a timely fashion, right? The patient may suffer, the patient may die, the patient may develop some kind of sickness, disability, or even die, okay? It's important because the response time is important in achieving a certain outcome, okay? Hopefully an outcome that matters to the patient, hopefully an outcome that the insurance company is willing to pay for, and hopefully an outcome that the physician desired. So, in terms of a geriatric emergency, it's an acutely debilitating or life-threatening condition in an older adult. Okay, we sort of commented on some of the guiding principles in medical ethics. And I think this has to do with, forgive the question on top, why is identifying an emergency relevant? The guiding principles in medical ethics actually has a lot to do with what Dr. Gerard just mentioned. Important to whom? Relevant to whom, right? So is our intervention, for example, if a patient presents to your office for a general checkup and the patient passes out, the patient faints or syncopizes, right? What should we do about that? Now, Dr. Gerard asked a question, important to whom? So it would be good to know what the patient wants, but there's certain guiding principles that sort of drives what we do, we as healthcare providers. It drives what we do in the absence of information, right? There are certain assumptions that are made. For better or for worse, there are certain assumptions that are made, okay? And some of those guiding principles has to do with, one, yes, respecting patient autonomy, assuming the patient has capacity or someone else. Two, obtaining informed consent, but in the context of an emergency and the time constraints and patient who may not have capacity, there are certain question marks there. Three, beneficence. And four, non-maleficence. Okay, so these are some guiding principles that we use to drive or to dictate why we do what we do. Many of us, I don't know in the other specialties, but certainly I took it at the end of medical school. Does anyone want to comment on the NPs and others? Do you guys take a variant of or actually take the Hippocratic Oath on graduation? I hear no comment.
We don't.
You do not?
No, we don't have a Hippocratic Oath. We have sort of a contract of, as you said, beneficence and maleficence, not to do any harm, to treat the patient to the best of our abilities, but not what is done in medical school as a Hippocratic Oath, no.
Right, go ahead. Yes, Dr. Gerard, you're muted. You have to unmute. You have to unmute. But in essence, the guiding principles are the same, right? To do no harm and actually do good, to minimize harm and do good, right? Why is this relevant? The population is aging. And by virtue of that, we would encounter more problems, more emergencies. If you have a larger fraction or a larger subset of the population being older, then it reasons well that you may have more geriatric emergencies. So aging is inevitable. Some of the similar information we shared on the previous presentation. As much as 75 million Americans are going to be over the age of 65. In Brooklyn alone, they're in excess of 300. This is an old slide, but they were in excess of 300,000 elderly residents living in Brooklyn. Okay? This is relevant because our interventions result in a decrease in morbidity and mortality. What we do save lives, okay? What we do improves quality of life and it saves lives. What we do impact independent functioning. It impacts a patient's ability to perform ADLs and IADLs, okay? Why is this relevant? Because it is relevant because the situation, an emergency, it serves to guide our assessment. Okay, and I'll spend more time on that later on. But if a patient is presenting in an unresponsive state, our assessment approach is different than if a patient is walking into the clinic. Okay, so for example, if a patient is with a known history of let's say diabetes on insulin or diabetes on a sulfonylurea, which is a medication that increases the secretion of insulin from the pancreas, if a patient is presenting unresponsive, having that history, we would think of things like low blood sugar. And we would act quickly to correct that low blood sugar. That would be different than if a patient is walking into our clinic, okay? And the response time matters. So the setting of an emergency, it guides our assessment and it guides our physical exam too. If a patient is unresponsive, we're thinking of ABCs, okay? Airway, breathing, circulation. We're thinking of, assessing the airway ensuring that the patient is breathing, ensuring that there's an adequate blood pressure, there's an adequate pulse. That is different than if a patient is walking into the office. Again, you know, we're going to do those things, but it will take some time. We're not going to be as aggressive in terms of getting to that, because the time constraints is not there, and the response time is not as critical. The physical is important. So the emergency situation guides our physical. Okay, what we assess. The emergency situation guides the tests that we order. Okay, the blood work, or whether or not we order any imaging. And some of the things we have to do, I have to consider, has to be what's the indication for these tests, and how long will it take for a report to come back. For example, and this is so critical in terms of guiding our assessment, guiding our history, guiding our physical, guiding the blood work that we order, guiding the imaging that we order. If a patient is presenting in an unresponsive state, okay, yes, a CAT scan of the head may be important, but a CAT scan of the head may take time. And so that may not be the first test to do. The first test may be ABCs. Okay? What does it take to assess the airway? What does it take to assess the breathing? What does it take to assess the circulation, the vital signs? Vital signs including the pulse ox, meaning the oxygen level. Vital signs including a serum glucose level, the blood sugar level. So a question has to be asked, what is the indication for each and every step that we take? What is the indication for every test? Not so much the cost, but certainly the risk, the time to get the report, and what we will do with those results once we get it. Are there any questions in the chat so far? Emergency situation also guides how we question things. Certainly common things occur commonly. Again, a patient with a prior history of syncope or passing out with hypoglycemia, it helps to put that at the top of our differential if the patient is presenting with similar complaints, or the patient is coming with a similar presentation. So the previous episode is a predictor of a recurrent event. And we should, you know, to some degree minimize looking for the esoteric stuff, looking for the zebras. This question is important. Did I ask? Okay, and consider the differential from previous. Did I ask? Did I ask the questions? This stands for drug, infection, dehydration, impaction, and angina. And this had to do with the presentation I gave previously of an older adult with some sort of baseline dementia who became agitated or became combative, or maybe started acting up. Patient is not acting up just because. There's something that triggered it. There's an underlying cause to it. So we have to consider all the possibilities. Vascular reasons, infection, trauma, autoimmune causes, metabolic causes, idiopathic, neoplastic, meaning cancer, and drugs or substances in psych. So what are some of the questions and some of the important questions that we should ask in the setting of an emergency? One of the most critical questions to ask, and we may not necessarily stop to ask this question every time, but we do it. What is the next step in the management of this patient? What is the next step in the care of this patient? But we can also ask it a different way. What is it that I need to do to make this patient, to ensure that this patient live, or to prevent this patient from dying? Okay, so what is the next step? That is a very important question. Again, a patient who comes in and is unresponsive because the patient has diabetic ketoacidosis. So in diabetes, in a severe case of diabetic ketoacidosis, the patient may have very, very high blood sugar levels, and the patient's blood may be very acidic. okay? And the patient may have electrolytes abnormalities, such as a potassium level being high, okay? So what is the next step in the management of this patient who's unresponsive? Again, a CAT scan to assess the brain to see if there might have been a stroke or if there's a mass or something compressing. A CAT scan may add value, but a CAT scan would take time. And a CAT scan, the time for the report to come back would also take time. And the patient may be too unstable to ship to the CAT scan area, to ship to radiology. So the next step in the management of this patient, even though a CAT scan may be beneficial, the next step is not necessarily to do a CAT scan, but to do measures that you can do quickly and that will save the patient's life. In a similar way, you know, a blood glucose is a quick test to get, okay? And that can have implications in terms of impacting outcomes. So what is the next step in the management of the patient? That is something, it's a very good question to ask, and it should be asked on a regular. Even in the outpatient setting, we should ask that question. So how do patients present? Patients who are having an emergency, how do they present? Those are questions we should ask. How do patients present? What signs and symptoms are suggestive of an underlying medical problem? What signs and symptoms are suggestive of an emergency? Okay, important questions to ask. It's important because, again, it guides our decision making, it guides our management, and it should translate into improving quality of life and life expectancy. We asked this question in the previous talk. However, it needs to be asked again. How does it differ from a standard medical evaluation? How does an emergency differ from a standard medical education? We're belaboring the point, but we're belaboring it because it's important. It focuses on elderly individuals with complex medical problems, that's the geriatric patient, but it also tells us that it is important to stabilize the patient first and then work on some of the other underlying medical problems. So the response time is critical. The response time is critical. And just as a reminder, a comprehensive geriatric assessment incorporates the multidisciplinary team. Where can we have an emergency and where can we handle an emergency? Theoretically, anywhere. In the ambulatory setting, in the acute care setting, in the patient's home, whether it's a skilled nursing facility, assisted living, or a home. These are examples of emergencies. Patients falling, patient in cardiac arrest. What are some of the most important things to do if a patient is found unresponsive? Or if a patient is having an emergency? The vitals, the vital signs. They're very important signs. Okay, the vital signs are important. ABC stands for airway, breathing, and circulation. We have to assess the airway, make sure that the patient has a patent airway, ensure that the patient is breathing, assess the patient's circulation. Ways to assess the circulation. Circulation has to do with blood flow. Blood flow from the heart to the various organs in the body, including the brain. Okay? A good way to assess blood flow has to do with determining the blood pressure, checking the blood pressure. Okay? So assessment of the blood pressure. Is it too high? Is it too low? Extremes of pressure, extremes of vitals. Is the pressure too high? Is it too low? Another way to assess the circulation is to check the pulse. Okay, how is the pulse? What is the rate? Is it too fast? Is it too slow? What is the rhythm? Okay, ABCs. The vitals may also include the oxygen saturation level, the SA2 or the pulse ox. That can give us very, very important information. So the pulse ox should be considered part of the vitals. In addition, the blood glucose level, the blood sugar level, which you can easily obtain from a finger stick, should also be considered part of the vitals. It has a lot of weight in the setting of a patient with diabetes, obviously. It's a very important part of the vitals. How do we treat the patient? Yes, we treat the underlying cause. Many times we may not know what the underlying cause is. So we stabilize first. We stabilize first. ABCs, airway, breathing, circulation, stabilize first. We take measures to prevent, yes. There's primary and secondary and interventions, but we stabilize first and treat the underlying cause. And that is important. It's important to know what the underlying cause is. So patient presenting, who's unresponsive, again, patient might have had some sort of opioid overdose, okay? Is a CAT scan important? Yes, a CAT scan may have weight, may carry weight and may help us, but in the immediate setting, the treatment would not be to get a CAT scan, but to give maybe naloxone, okay? Check the vitals, check the pupils, okay? Stabilize and treat the underlying cause. History and physical, most of the times, clinical diagnosis, okay? These are some examples of geriatric, what I consider geriatric emergencies. And I want to take a minute just to discuss some of them. Why are these examples of emergencies? Anyone cares to comment? What's the definition of an emergency? If it's left unaddressed, if it's not responded to in a timely fashion, if the response time is not quick enough, then the patient
could result in death.
Exactly. So these are emergencies that warrant immediate action. Okay, a stroke is considered an emergency. And part of why we do what we do, again, is because our intervention can help the patient, okay? There is a window to give TPA. There's a window to treat a stroke and to minimize the complications of a stroke. So a stroke is an emergency. A PE, pulmonary edema, pulmonary congestion, congestive heart failure. Those are emergencies, examples of emergencies. Decompensated heart failure, shortness of breath as a result of fluid buildup in the lungs. Okay, if left unaddressed, the patient can die. A pulmonary embolism, PE, DVTs and PEs are emergencies. GI bleeding, gastrointestinal bleeding, from below or from above, emergencies. Patient can become hypotensive, and a slew of problems can follow that. Can exsanguinate and die, yes. Rhabdomyolysis, skeletal muscle breakdown. When do we see rhabdo? When can we see rhabdomyolysis?
And long-term use of statins.
Long-term use of statins can give you myositis, yes. Muscle breakdown, yes. Is there a raised hand? I see a raised hand. Julie Park. When do we see rhabdo?
Julie, you can now speak. Yep.
So when the patient falls on the floor and remains on it for hours without being discovered.
Absolutely. Absolutely. Some of our elderly patients are at risk for falls. The home environment, the social environment is very important. And the patient falls at home on a Friday evening or a Saturday when the home attendant left. The home attendant returns on a Monday morning, finds the patient on the floor. Blood work is consistent with elevated CPK. rhabdomyolysis. Why is rhabdo an emergency? In skeletal muscle breakdown, yes. Why is that an emergency? Why would that be an emergency? Let's make this interactive. I like interactive.
Dr. Emmanuel also had his hand up.
Interactive. Why would rhabdo be an emergency? Skeletal muscle breakdown.
I need to keep, you can.
You're muted, Dr. Emmanuel. Unmute yourself, please.
That was my fault. I attempted to unmute him and instead muted him. Sorry about that, Dr. Emmanuel.
You hear me now?
Yes.
Yeah, it can lead to kidney failure.
It can lead to kidney failure, right? So those fragments of muscle breakdown, they move around, they float around, and they literally clog the kidney, which is serving as a strainer. So it clogs the kidney, and it can lead to acute renal failure. Why else can you? What happens when you break down the skeletal muscle? What's inside the muscles that spills into the bloodstream?
Myoglobin.
Myoglobin and any electrolytes?
Phosphate, potassium.
Hyperkalemia.
Hyperkalemia. And hyperkalemia can lead to arrhythmias, and arrhythmias can cause death. So rhabdo should be considered an emergency. Of course, the degree of rhabdo is important. Any other comments? I see 3 raised hands. I can't see who's raising the hand.
Dr. Akbar also had her hand up.
Yeah, I just wanted to mention that it causes the hyperkalemia and leads to arrhythmias.
Yes, absolutely.
So
Okay.
increase the phosphate.
Yes, absolutely. And
It
so
also increase the phosphate content of the blood.
absolutely. So the point is that this emergency, the nature of the emergency would dictate our response, right? It would tell us how to treat the condition. Okay. Clearly, cord compression is an emergency, and it warrants an emergent consultation, an emergent referral to a neurosurgeon. Okay. Hyperkalemia. Okay. Emergency. Temporal arteritis. What is some of the complication of temporal arteritis? It's a problem that can be treated very easily, but what are some of the complications of temporal arteritis? I see 3 hands. I cannot see you, so feel free to speak. Anyone?
Yes.
It can lead to blindness.
It can lead to blindness. Yes, vision loss. Absolutely. Yes, go ahead.
It can lead to a stroke.
It can lead to a stroke in the eye and maybe stroke in other places. Yes. Okay. Where else?
It also has an association with abdominal aortic aneurysm.
Ah, I have to verify that one. But yes, I'll take your answer. It sounds plausible. What else? So if someone presents with signs and symptoms of TA, temporal arteritis, what's the next step in my management? Should I refer them for a temporal artery biopsy? Which is
Steroid first.
Which would probably take a couple of days, maybe even a week? Or should I respond faster with an intervention? Yes, steroids, right? Can save that patient's life and save the eyes and save a lot of other things. Okay, so the response time and the nature of the response is critically important in a geriatric emergency. Why are hip fractures emergencies? Okay, we'll come back to that. Depression could be considered an emergency. Can anyone tell me why would depression be an emergency?
Untreated could lead to self-harm.
Absolutely. 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 Okay. What about a tooth abscess?
Sepsis.
An infection, sepsis, meningitis. Okay. I don't know why I have the eyes here, but any insult to the eye, I consider emergency, and I automatically refer to ophthalmology because I'm a little bit limited when it comes to eye problems, with the exception of maybe some sort of conjunctivitis or something of that nature that I can treat. But otherwise, I involve the specialists, a pneumothorax, obviously, acute kidney failure, and acute abdomen. Okay, so these are all examples of geriatric emergencies. Okay, we're going to spend some time on a pulmonary embolism, but so in terms of the assessment.
I'm sorry, Dr. Prospere. So in the chat, you have some responses to your hip fracture question. So there's embolism.
Yes, there's embolism, correct?
And PEs.
And PEs, pulmonary embolism and PEs. Pulmonary embolism, which is PE. Now, I'm going to be a little more specific. What kind of embolism?
A fat embolism?
Yeah, that's a board question, right? A fat embolism. But not only that, and that's correct. That's absolutely correct. But can anyone comment on the mortality rate if a hip fracture is left unaddressed? Can anyone comment on the mortality rate within a year? So the mortality rate is high, right?
Yeah.
It's very high. You should know that. And so we need to intervene quickly. Okay. Hip fracture can lead to blood clots. It can lead to fat embolism or DVTs and PEs and fat embolism, two types of embolism. It can also lead to deconditioning. Okay. Deconditioning. Patients can become withdrawn because they're very apprehensive about falling again and fracturing something else or hurting themselves again. They can become withdrawn, so it can lead to social isolation. It can lead to depression. And these are some of the reasons why it's important for a geriatrician to be involved in the care of an older adult. The pulse can tell the story because the geriatrician is most likely to look for those underlying issues. The pulse can tell the story in the context of an emergency. So what I like to say here is look at the extremes of the pressure. Look at the extremes of the vitals. In this particular case, we're talking about the heart rate or the pulse. Okay, look at the extremes of the vitals. So in the setting of a tachycardia, what is the differential for tachycardia? What are the possible underlying causes to a rapid heart rate or a rapid pulse? Right, and we gave the acronym earlier. The acronym was vitamins, right? And so we think of vascular reasons, we think of infections, we think of trauma, we think of autoimmune, metabolic, idiopathic, I don't know, iatrogenic, neoplastic, or cancer, and substances. In this case, tachycardia can be caused by medications. Is that true? Rapid heart rates can be caused by medications. Medications can have a side effect or adverse effect, which results in tachycardia. Is that true?
Yes.
Yes, absolutely. Are there any commonly prescribed medications that causes tachycardia? Can anyone identify one?
Albuterol.
Absolutely, absolutely. Okay, albuterol. Okay, beta agonist. What about infections? Can infection cause tachycardia?
There's one comment in the chat that says beta blocker rebound.
Absolutely. Absolutely. Okay. Can infections cause tachycardia?
Yes, absolutely.
Yes. Right? Fevers can result in a rapid heart rate. Infections can cause dehydration and even sepsis. The heart attempts to compensate to maintain the pressure so it beats faster. Okay, and dehydration, again, similar concept, similar mechanism. Okay, dehydration. Body's attempting to compensate to maintain the blood flow, and so the heart increases in rate. Anemia, yes. Hyperthyroidism, yes. What about heart attacks? Myocardial infarction manifests with tachycardia. Is that true?
May or may not.
Pardon?
May or may not.
Absolutely. It may be bradycardia or it may be tachycardia. So it may or may not. That is correct. And obviously a PE, we'll spend more time on a PE in a minute. And we can also see bradycardia in all these examples, in infections, in hypoglycemia, in sick sinus syndrome, in hypothermia, hypothyroidism, changes in the intracranial pressure, and infection is duplicated. So I wanted to speak on PEs briefly because it is so common, right? It is so prevalent, and not only that, but in the recent pandemic, in the COVID-19 pandemic, a tremendous amount of patients, and I think that is part of the pathophysiology, a tremendous amount of patients developed blood clots and pulmonary embolism, right? A pulmonary embolism is basically a blood clot that travel to the lungs, usually from a deep venous thrombosis, a clot in the leg, let's say, usually 90% of the times. There are as many as 500,000 cases in the US annually. And this is important because if left unaddressed, if left untreated, as much as 30%, the mortality rate approaches 30%, okay? The flip side of that is that it is treatable, and we can decrease the mortality rate tremendously, okay? It can be dropped to 10% with early detection and treatment. What are the risk factors for pulmonary embolism, DVTs and PEs? It's virtual triads, but it's really stasis. There are 3 risk factors: stasis, immobility, and as we mentioned previously, the importance of the 4 M's framework and you know, age-friendly healthcare systems. We mentioned previously that mobility is an important part of the assessment. But here we see mobility or stasis as one of the contributing factors to DVT and PE as part of Virchow's triad. So stasis, usually from immobility, right? Patients who take long trips on, let's say, on planes, or I had a patient who had a DVT from a long bus ride to another state, okay? Stasis, stagnant blood or decreased blood flow, endothelial damage from surgery or trauma, and a hypercoagulable state, which may be a sign to look for an underlying cause, right? What are some of the signs and symptoms of a DVT and PE? How do patients present with PEs? How do they present? A sign is what you see. So what are some of the signs? Shortness of breath. Go ahead, Sahima.
So a patient will be tachycardic, patient will be hypoxic, and otherwise patient might have some dyspnea, complain of some chest pain, but mainly it's tachycardia and hypoxia that we look for.
Absolutely, right? So, and it's here also. The signs is what we see. So patient may look short of breath. Patient may complain of having shortness of breath, of dyspnea, right? And this is a very sensitive sign, but it's not very specific, okay? Because you can find dyspnea in other conditions, in asthma, in CHF, okay? So it's very sensitive, but it's not specific. Pleuritic chest pain. Pain when you take a very deep breath, pain in the lower parts of the lung area, pleurisy, okay? Sensitivity is about 50%. Patient may experience chest pain that mimics heart attack, you know? So angina-like chest pain, coughing, hemoptysis, coughing up blood, and swelling in the leg. These are some of the signs and symptoms of DVT and PE. Clinically, we touched on tachycardia. Tachypnea is rapid breathing, okay? And physical exam, if it's actually done, it's good to do a physical exam. Physical diagnostic skills are very important. And accentuated P too. You look at the hands to see depending on the degree of hypoxia, poor oxygen concentration in the blood, the hands may look cyanotic, may look blue. Okay, these are some of the signs of a DVT and a PE. Fever and a Holman sign. What is a Holman sign? Does anyone remember what a Holman sign is?
Yes.
Go ahead.
Yes, there is pain when the patient's foot is dorsiflexed.
Ah. What is a pleuritic rub?
Isn't like that's a pain when the patient takes deep breathing?
And does the position matter? They lean.
Yes, they lean backward. That worsens the pain, and leaning forward will relieve the pain.
So the history and the physical is very important in deciphering the underlying problem, right? And just to backtrack, it's always good to look at the vitals, okay? Look at the vitals. The vitals, the blood pressure, the heart rate, the respiratory rate, the temperature, the pulse ox or the oxygen saturation or SA2, and to some degree, the serum glucose, okay? They give you important information. In this context, less so the glucose, but all the others are very important. Now, how do we diagnose a PE? So there's several, go ahead.
It's like the CT chest.
So CT chest is one modality, yes. There are other tests that we can do that can point us in the direction, depending on where you are and depending on the availability of resources and depending on the availability of testing, okay? But an EKG can give us some information. It can show us tachycardia, but that's, you know, that's not 100% of the time. It's not the most sensitive way. You can have non-specific STT wave changes. And there's an EKG finding, which is very rare. But if you see it on the EKG, it's usually pathognomonic of, okay, but it's very rare, okay, the S1Q3T3, okay? What about a chest x-ray? Can we diagnose a PE on a chest x-ray?
No.
Yeah.
Yes?
You won't diagnose it, but it can give you a clue because you can look at the widening in the sternum. Not only that. That is a aortic dissection. Not really. It can just give you exclude other things, but you wouldn't be able to diagnose a PE on it.
Right. So it may have findings that are consistent with a PE, but it's not definitive because it's not very specific, right? Some of the findings that you see, for example, in the setting of a PE, a chest X-ray may be normal. That's number one. In the setting of a PE, also you may see infiltrates which may be present in other things, such as infection. So the clinical scenario is important. Also, in a PE, you might see pleural effusion, but that also may be indicative of other underlying issues, like cardiac issues. So there are findings that may be supportive of, but it's not definitive of, right? Yeah. What about an ABG? How is an ABG helpful?
It can just show you like a respiratory alkalosis.
So first and foremost, it can give you the acid-base status. Second of all, it can give you degrees of hypoxia, right? So this is all very important stuff. It adds value. So what is the gold standard? Because there are a lot of tests that we can order. What is the gold standard, most definitive test to determine if a patient has a PE?
Pulmonary angiogram.
Angiogram.
Absolutely, but we don't always. So a high resolution chest CT is used most of the time, right? How do we manage it? How do we manage a PE? How do we save the patient's life?
Anticoagulation.
Anticoagulate him, break the clot. Like depend on if it's saddle embolus, then definitely we have to go for like probably intracatheter by IR.
Say that again.
If it is saddle embolus and patient is clinically unstable, we have to we might have to take the patient to a catheter ablation by IR guided.
Okay, so those comments are correct. So the management depends on the patient's presentation, right? The management depends on the patient presentation, and the management depends on how the patient is doing clinically. If the patient is hypoxic, right, what do? We want to give oxygen, right? If the patient is hemodynamically unstable, then we have to consider whether or not this is a major embolism that may require someone going in and removing the clot, right? Versus simply giving anticoagulation. So the patient's clinical situation dictates the intervention, right? And there are many options. I'm not going to get into it, but the patient needs oxygen. The patient needs anticoagulation. Depending on whether or not it's a saddle embolus, which is a big one that sits right there in the bifurcation area, we may need to go in and remove the clot, okay? And treat underlying cause. Of course, we treat the underlying causes. Whatever triggered it, we have to try to address. It is good to try to address those underlying causes. It is exactly 4:59. I'm going to open up for questioning, please. Any additional questions or comments?